Hello, everyone. Welcome to one more webinar about the sniper technique. It's a privilege to be here and to present a few additional details. This is part 3 webinar, and we'll be talking today about some details regarding the sniper technique in central venous occlusions. My name is Marcelo Guimarães. I'm a professor of radiology and surgery at the Division of Vascular Intervention Radiology, Medical University of South Carolina. And I appreciate, thank you to Baylis for the opportunity to be here. So let's review what we have done so far in webinar part 1. We reviewed the patient evaluation in clinic, patient selection, and pre-op imaging, and the importance of having and reviewing the anatomy in detail before we start any procedure, advanced imaging techniques that can facilitate the procedure and increase safety. And in part 2, we discuss about the technique, tools, equipment, room setup, some technical details on how to prepare to manage complications. Today, the goals are to discuss a little bit more about the sniper technique in detail, some tips and tricks, and also some imaging applications that can be helpful to increase safety and to help you during some challenging cases. So first of all, before we use the sniper technique, it's important to make sure that we use conventional technique first. So this is critical. And in every single case, before we use the radiofrequency wire, we always try to open up, for example, a glide wire and the best combination of cathode wire to try to recanalize. And this is a classic example of a failed attempt to recanalize the brachycephalic vein on the right side. As you can see, the guide wire is somewhere in the mediastinum. And once we fail, then we definitely can use the sniper technique. But it's important to follow this initial step. So the technique in a few words, basically in one side of the occlusion, as you can see here, for example, on the left brachycephalic vein, you have a 10-millimeter snare that can be advanced through a 5 mm French catheter. We typically use the end snare, and that's the 10 millimeters is the only one that goes through a 5 French catheter, so they can give you direction. And on the other side of the occlusion, as you can see, we have the radiofrequency wire, typically use a straight wire, 0.35 to 150 cms, in combination with a semi-curved 5 French catheter, again, to give direction. In some challenging cases, especially in the left brachycephalic venous recanalization, sometimes there is the stump is more posterior, then we have an anterior approach, the more posterior target, then a semi-curved wire with a semi-curved catheter might be needed. But what has worked for us over the years is to use this combination that I just described. And then you slowly cross that occlusion with a few millimeters each time. Once you reach the snare, you just stop activating the radiofrequency wire. Then you just advance as a regular guide wire and then snare it out, exchange for a stiffer catheter, and then you can do balloon angioplasty and stent placement as you wish. So a basic thing that we do in every single case is once we define that the conventional technique failed, then we're going to get access also, and typically get access on the patient's arm or the patient's neck, ipsilateral to the occlusion. Then what we do is we get also access in the femoral vein, either right side or left side, in order to have a dual venous venograms, in order to define the anatomy well. As you can see here, and then we inject simultaneously from above and from below, in order to understand the collaterals, to understand the length of the occlusion, the diameter of the stumps. As you can see in this image, lower image in the central lower image, you can see it can be quite complex. So it's important to take multiple views many times in order to understand exactly where you're going to be using the radiofrequency wire and where you're going to be putting the 10-millimeter snare. So in other situations, and that's what we have done more frequently now, we actually perform a cone beam CT at the beginning of the case, in order to clarify better what stump we need to connect with, basically to define the anatomy well. So as you can see, sometimes it can be very, very challenging. Other important thing when you do is to define multiple views, right? So you can either do RAO, LAO 30 degrees, LAO 30 degrees as well in order to define. You can see the first two pictures on the left side. They are good. They are relatively aligned, the stumps. There's an occlusion of the right brachiocephalic vein. And you can see we have the catheter in those two stumps in a good position. They're kind of relatively in alignment, which is not the case when you do the other oblique, and you can see we're total different planes. So we need to step back, and I try to take the time to investigate well. In this case here, I was already not in the SVC, but I had the catheter in the left brachiocephalic vein, and that's why we're not aligned. And then once we pull back into the SVC, we're able to redo the images again in AP, RAO, LAO, and now you can see there's a perfect alignment in all the views, and that's give us the objective assessment that we are safe to use the radiofrequency wire, the PowerWire, and go through that fibrotic tissue that is basically causing the occlusion for this patient. Alternatively, as I was saying, and that's something we've been doing now on a routine basis, is to inject hand inject contrast from above and from below, from both sides of the stumps, and do a cone beam CT. That has been super helpful, and I think it has added value to the way we've been doing things. In order to understand really well the anatomy, we can correlate with the aorta, we can correlate with the lungs, in other words, with the adjacent tissues, in order to define the track and define the anatomy very well. We can also do some 3D reconstructions and we define with that red line where we need to go. This is, of course, in a 3D model with the subtraction of the surrounding tissues, but you can leave those surrounding tissues and then define really well what's their safe path. When you perform the sniper technique, the approach can be a caudal-cranial direction. It typically has a lower risk of cardiac tamponade because we're coming from the heart towards the venous stump that is more cranial. However, it's more unstable with the heartbeats, and then it's good, as you can see here, to use a long introducer sheath, a 65 cms introducer sheath, in order to give you some stability because of the heart. We can also come from a cranial caudal approach. We typically have more stable access because there's no heartbeat coming from above with the radiofrequency wire. Typically have a larger target as a re-entry point, but there's a higher risk of cardiac tamponade because you're basically going towards the heart in that direction. One basic technical principle that is important to share is that the radiofrequency wire can be used in different ways. So like in this case, for example, on the left is a short segment. You can activate the radiofrequency wire for the entire time while you are connecting one venous stump to the other. Another way to use it, you can use the radiofrequency wire like in this image on the right, and you can use that to get out of the stump, because every time you have that U-shape stump, it's very hard to find exactly where to go. If you have a pencil tip, typically you can use conventional technique and recanalize without any sniper technique. But if you have a U-shape in both sides, as you can see in these two cases, then it's very hard to find exactly where you need to go. So you can use the radiofrequency wire as an out to get out of the blood vessel, to get into the mediastinum space. And then it's your choice. You can try to advance if it goes well. If it's not non-fibrotic tissue, you might be able to go through the mediastinum without activating the radiofrequency wire, and then just use it again as a re-entry to the other stump, towards the snare. But if there is a chronic fibrotic tissue in that occlusion, then you are not going to be able to navigate with the radiofrequency wire just as a guide, or just with mechanical pushing it. You won't be able to recanalize, and you need to activate the radiofrequency wire all the way through from one stump towards the other, and having activation all the time. However, we recommend to have small increments, as I'm going to show you in a minute here. So it's small advancements every time and not simply a single shot all the way through. It is critical before activating the radiofrequency wire that the grounding pad of the system, as it is a monopolar system, the grounding pad is attached to the patient's thigh. And then you need to also check, once the radiofrequency wire is in, if the catheter, the semi-curved catheter, is aligned with the snare. Sometimes I use the central portion of the snare as a target. Sometimes I use this transition between the 5-French catheter and the snare. In the transition here, I think you can see my pointer as a target. So you need to define one target and then use that to make sure that they are all aligned in AP, in 30 degrees LAO, 30 degrees RAO, and then you are good to fire the radiofrequency wire. If you don't get them totally aligned, you can't do it. You can't activate. Like this is a good example that in the last two views of the left, two images of the left, you can see that they are pretty much aligned. There's a good alignment between the radiofrequency wire tip and the snare. But if you take a look at the image on the right side of the screen, they are not aligned. And that's where the dangerous, that can be dangerous. You can go through structures that you don't want to. In this case, for example, this was one of the longest occlusions we ever recanalized. This was a 7 centimeters long. We went slowly, a few millimeters each time, and checking RAO, LAO to make sure you're in a good spot. As you can see, we're progressively going cranial, but then eventually we're not able to get to the snare when we checked in an oblique. And so no problem. We pulled back the PowerWire halfway, and then we redirected with the 5-French catheter, and we were able to reach the target right there. We're not going through the snare here. We're just facing the snare. But then we just activated from there, and we're able to snare it out and then deploy the stent very safely. As you can see in the video on the left side of the screen, you can see that we typically, I'm going to show here, what we recommend is to advance the radiofrequency wire for a few millimeters like I showed here. You should stop, check RAO, LAO, 30 degrees, make sure they're all aligned. There's alignment between the tip of the radiofrequency wire and the snare. Then advance a few millimeters more, check it again, and then complete your maneuver once you feel comfortable that you are fully aligned until you reach the snare. This maneuver here, it was done in one shot slowly because we feel comfortable after doing hundreds of cases that we can be safe in short segments, but we do not recommend to go in one shot in for the first few cases in order to protect your patients. And then once we reach the snare, you just snare out and then use the body floss technique. Basically, you're going to once you snare out the radiofrequency wire or the PowerWire, you exchange that 250 cms wire over using a 125, 130 cms vertebral catheter, for example. You can go through and then remove the PowerWire, put a 260 amp Platts, remove the vertebral catheter, for example, and then you have basically access through and through from the right arm or right neck, for example, to the groin, or from the left side to the groin. And after that, we recommend to use a 4-millimeter balloon. You don't need to pre-dilate bigger than that. In case there is some bleeding, there's going to be a small bleeding, can be easily contained with a 4 millimeters than if you go with a bigger balloon. And then you simply go and put your stent. That can be bare metal stent or can be cover stent. We covered that part, that topic in the webinar part 2. So one thing is important to mention that we prepared, especially if you're going to do lower brachiocephalic venous recanalization or cavo recanalization, we always have the cardiac window prepped. What I'm trying to say is we have the subxiphoid space is all prepped and draped. We have the cardiac probe or the curvilinear probe turned on already with the probe cover. with gel, with a window to the heart already marked in the patient's skin. We only perform these procedures where CT surgery and cardiology are available in case there's a complication that we cannot resolve. We always have a pericardium tray handy, and we have somebody that is assigned to open that up quickly in case there's a cardiac tamponade. We define clearly before we predilate the segment that needs to be recanalized. We always assign everybody who is in the room what they need to do. Somebody's going to call cardiology in case we have a complication. Somebody's going to open up the pericardium tray. And we discuss that with the anesthesiologist that is in the room in order to make sure they keep an eye on the vital signs. And of course, all these cases are performed under general anesthesia. We actually like to do a baseline imaging of the heart to see if there's no fluid. As you know, some of these patients are dialysis patients. They might have a little bit of fluid already in the pericardium sac. So it is important to have the baseline picture. And then throughout the case, every few minutes, we keep checking to make sure there's no accumulation of fluid, despite the fact that the anesthesiologist is saying that everything is okay. We can continue to check every few minutes to make sure everything's fine. We can capture, if there's any pericardial effusion, we can capture that early on and take action and drain it as needed. One thing that we have changed in the technique, and this is part of the evolution of technique or improvement over the technique that we described over the years, is this part, is over the same 0.35 260 amperes wire. From one side, we come with the pre-dilation 4 millimeter balloon for pre-dilation. And as you can see, the two markers of the balloon here, that's deflated. But in between the balloon, just above the balloon, you have a stent, as you can see here, a cover stent that is important, especially if you're going to do cable reconstructions. So what we did here is we don't want to have any time. We want to minimize the time between predilation and stent placement, because if there's any tear of the pericardium sac, or bleeding anywhere in the chest, we want to make sure that we can cover that immediately. In other words, we predilate with the balloon, and we mark the screen or use overlay or roadmap. We've defined clearly where's the beginning of the stent will be, where the end of the stent will be. We predilate with the balloon, let's say, coming from below here, and then we immediately pull back the balloon, and in a second after we come up with the stent, deploy the stent, so there's no time for bleeding anywhere in the chest. I think that doing this technique, we are able to prevent cardiac tamponade and other bleeds in the chest when we use the sniper technique. So it's important, small, but important detail that has worked for us. As you can see here, we're just pointing from in this case, from above, we're coming from the predilation balloon, and then coming from below, we're coming from with the stent, cover stent. This is an example of what happened to us after 34 cases. We had a cardiac tamponade in this type of reconstruction. It was a long segment of venous occlusion, and this is the type of situation that we do want to avoid. And today, the way we all like to avoid is exactly what I'm describing here. We mark the screen with in this case, with the yellow markers here on the slide, but we literally mark on the screen of the angio suite and predilate and deploy the stent right away, as you can see. Another important detail is to be careful and not to jail out the contralateral brachycephalic in case you are reconstructing the brachycephalic vein. For example, here there's an occlusion of the brachycephalic on the right. Sometimes we prefer to use an angiography, a second catheter from below, to define exactly where we should stop and leave the catheter there to stop where we should stop our stent. Sometimes you just do a venogram, and then you define by drawing or using a roadmap. And sometimes the patient has a contralateral dialysis catheter there. We leave it there for reference. In other words, have some type of reference to know exactly where to park your stent, and then have a precise deployment. As you can see here, we have a little bit of back flow into the brachycephalic on the left, showing that the stent was placed precisely without jailing out the contralateral. Most of these patients we treat are dialysis patients, or they have some sort of chronic need of venous access. And these patients need access to the heart. So do not avoid everything you can to jail out the contralateral. And so another key point is it's important to identify the correct venous stumps, take all the time. It's important to check in multiple projections if there's alignment between the radiofrequency wire and the snare in AP or PA and the RAO, LAO, 30 degrees. Advance the wire very slowly, small increments each time, check in every few millimeters, check in the 3 projections, then advance a little bit more, check it again, and make sure that you're protecting your patient, doing things adequately and safely. And consider a cover stance anytime you recanalize the CVO segment, and don't jail out the confluences, as I mentioned before. So in conclusion, the radiofrequency should be only used in symptomatic patients. It's important to select the patients well according to the chest CT venogram. Get prepared to manage severe complications, including preparing the subxiphoid window. Use anesthesia in every case when possible. We use anesthesia in 100% of our cases. We don't use heparin. That has been our protocol. We don't use heparin anytime we are going to use the sniper technique, because in case there's bleeding, we're going to make sure that we can control the bleeding in an easier way than to use heparin. If we were going to do a regular angioplasty with conventional technique, we always use heparin, but not in the sniper technique. So in conclusion, the sniper technique is a good alternative in the recanalization of chronic venous occlusions when the standard techniques have failed. It's a privilege for me to present the sniper technique in detail, and I hope to see you soon. Thank you.